I won't take much time, but I come from a very different perspective. Although I'm an enthusiast in everything that is Indian and Ayurvedic, definitely. I'm a surgeon. So if we can start the presentation, please. So next slide, please. So my practice is predominantly robotic and laparoscopic surgery. Next slide, please. So I qualified in India. I did my MD in islet transplantation and stem cells in Oxford, and then I've got my MRCS and FRCS from the Royal College of Surgery of Edinburgh. Next one, please. So this is how much I've traveled within the UK, training at different places. And next slide, please. And I also had a traveling fellowship from ALSGBI, which is the Laparoscopic Surgeons Association of the country. And as a part of it, I get a chunk of funds. I travel to apex centers. Of course, I had to include India in it and Japan. So I brought back a lot of techniques and tricks from there. And this is where I work. I work in Chelmsford, which is a tertiary center. Just click, please. Yeah, so that's the referral center, and we've got about 2.5 million population where we operate and treat patients with mainly esophageal and gastric cancer. So, one of the things which I want to, listening to so many Ayurvedic physicians and Ayurvedic thinkers and how Dr. Polishetty's algorithm is so exciting. We have nothing like it in modern medicine. We do have, the physiology is very different. What we understand, we don't have the concept of BPK. We have a very different concept of how we have to approach the patient and everything else. There's one thing which strikes to me all the time. Every speaker has said either it's complementary or in addition to the modern medicine and things like that. So that is something which I'm very reluctant to accept because if you all believe in Ayurveda, Ayurveda was once the main medicine or main treatment, and now why and how should it be complementary? So I think I don't know. There is a basic thought process. I'm not an Ayurvedic physician, but if you're trying to promote something, if you're already starting off saying it's complementary, then that means, well, you can have some treatment, but you can also have this. That's the impression everyone gets. I will tell you my own experience. As I said, my specialty is with esophageal cancer, and I had a patient coming to A&E where I was on call, saying he couldn't eat or drink anything. So he was completely dysphagic. We did not know anything about him. We didn't know the patient. So we thought there was perhaps a chunk of meat which got stuck in the lower esophagus. So took him to theatre, put him to sleep, and put a scope in. And what I saw is two hind legs and a tail of a mouse. Oh, yeah. So he went to a Chinese doctor who told him that if he swallows a live mouse, it'll eat the cancer away. So the cancer was not gone, and now he's got a complete dysphagic with a full mouse stuck in his cancers. So this is the impression that general public have. And and then the nurses said, oh, this is why you should not go to these doctors, this and all that stuff. So my feeling is that, if I say, I'm going to give you chemotherapy, but that's as a complementary, then they won't have it. I will say, I'll do this big operation to you, but I'm doing it as a complementary. You can have something else, then they won't have it. They won't have it. It's a big cancer. It's a life-threatening cancer. So next slide, please. I'll just go through my own journey, and I have no insights, and I'm literally nowhere near all the clever people I've just heard talk and speak. So this is my practice. Just click through this. Just illustrates what my day-to-day life involves. And click, please. Yeah, next one. And next, yeah, this is where I was talking about. And my practice is predominantly endoscopic, laparoscopic, and robotic surgery. Endoscopically, if I find a patient who's got an early cancer, I remove them endoscopically, save them a big operation. Most of my patients that come to see me with cancer need to have big operations. They are not simple operations, little lump there, little lump here. So esophageectomy, I'm not sure. There are lots of MBBS doctors in the room. It takes good 7 to 8 hours. We operate about 2 to 3 hours in the abdomen, 2 to 3 hours in the chest. We collapse the lung for about 2 to 3 hours, and they wake up after that. And you just, yeah, you don't know. I mean, I did an operation on a very early cancer 2 weeks ago. She's just about recovering from her lung problems. Her operation was very, very straightforward. Didn't expect any problems, but these are big operations. That's the bottom line. So my practice has been predominantly moved to keyhole surgery. Yeah, next slide, please. This is historical. This is not even my pictures. This is what they have to have. Big cuts in the tummy, big cuts in the chest. Some surgeons take out ribs and things like that. Whereas my practice is predominantly keyhole. Next slide, please. So this is how my patients, the abdomen is not projecting, it's very bright, but he's got about 5 or 6 small cuts. And the biggest cut is in the chest. Click, please. So that's the biggest cut he's got, through which I remove the specimen. It's about 5 centimeters. So it doesn't mean the operation is any smaller, but it means that they will have less pain, therefore they recover quicker in the immediate post-operative period. The cancer is cancer, it won't go away. But next, please. Again, this is a cancer which was much more extensive, and I had to take the stomach up into the neck as well. So next, please. So I also do robotic surgery. I did my first robotic esophagectomy in 2016. We are the first ones in the UK to do a robotic esophagectomy. And next click, please. My parents had come, so I took them into theaters, and was one of my proud moments. Next, please. So during all this process, I just couldn't go in and start a new procedure and say this is good and things like that. Throughout the process, I had to produce evidence. I had to say, first of all, listen, it can be done. So feasibility. Next one, please. And then we talked about comparison. So what happened this year compared to last year? So we compared my patients that I operated on keyhole surgery this year to compare to exactly the last year. What were the changes? Next slide, next clip, please. And then we did a big study combining a huge number of patients. And this is still, even till date, remains the biggest study comparing completely minimally invasive and open surgery or hybrid surgery in this case. Next slide, please. And then we went further and said that we can use technology to improve outcomes. And we said we should use three-dimensional laparoscopes and stuff like that. And then finally, click, please. And then we got the whole region involved, and we published bigger numbers. Now, if anyone comes to me, I mean, this is still a very minority of surgeons in the UK do this. The majority of the surgeons still give open cuts and all this other stuff. So if someone comes to me and say, why are you doing this? Now I can show them, this is the evidence. I've shown you these are better, right? This is not 1 patient, 2 patients, 10 patients, there's evidence. I mean, I'm preaching to the converted, but I'm just going through my own journey to make a point. That's all. Next, please. Therefore, it's quite important to publish evidence, as all of you have done quite consistently. But as Dr. I think you were saying that there was a prejudice bias, a huge amount in regular medicine as well. The last paper we published in 2022, where we had a bunch of centers, localized centers, combine and publish it. The editor of the journal was against it. He kept it on the shelf for about 6 months. We kept pushing. Tell us what we need to do. What did you find? Was there any mistake in that? No. But what is this? What is it? He just kept it on the shelf. Because he doesn't do it himself. He doesn't want to, because the data is there, out there. There's nothing, there's no ulterior motive there. There is no financial benefit here or whatever, but they still want to keep it. So the bias is very much there. And that bias I've been the receiver of the positive bias when I was in Oxford. So I published a lot of papers from my research in Oxford. A lot of times I didn't think they were worth publishing. but they got published because they were from Oxford. It's as simple as that. I'm not even exaggerating. I've got a lot more publications which I'll be proud of than what I published while I was in Oxford. So that, unfortunately, is just so frustrating sometimes. Next slide, please. And then the other thing, what I find is that we don't have to, shouldn't stop at just publishing it, but we have to project it. You know, in this day and age, as you were saying about the WhatsApps and the Instagrams and all this, we have to put it out there. You know, we have to say, this is what I was saying about, if you are saying something, don't call it complimentary. This is what we have to do. This is working. You know, this is actual medicine. If you're all talking about herbal medicine, well, they're all chemicals, just like any other chemical. So that's my view as an outsider, as a complete outsider. So this is what I feel. And then recently, this is what I was doing when Bamraji rang me. So I rode along from Cochin to Kanyakumari in my bike. So I took a bike and then rode from there with three of my friends. Went there, spent whole 11 days riding along that route. And then Bamraji was ringing me, can you come to this? Can you come to this? The reception was very intermittent. He thought I was ignoring his messages, but I wasn't. I said, okay, fine, I'll do it. But the reason, click please. Yeah, so went through a lot of India, which I'd never ever seen. Never ever seen. It's beautiful, beautiful. And then finally, my parents came to Kanyakumari to receive me at the final, at the last stage. It was beautiful. We three sat on the seashore, the southern tip of India. We saw the sunset, and it was beautiful. It was just amazing. So the reason why I put up these pictures is, click please. I had to go through. I didn't know I could tan. I thought it was dark enough, but apparently I also tan. I also burn. I did not know that. Next, please. So this is one of the most proudest moments of that bike ride. I stopped at Tumba. I don't know how many of you know about Tumba. Right. So Tumba is the birthplace of ISRO. Now, ISRO, all of us know. And while I was there, I was full of pride. Full of pride. This is where the whole project started, the Chandrayans, Mangalyans, everything started here, right? So I was so proud, took a lot of pictures and stuff. And then this was going on while Bamraji was trying to get me to give a talk and things like that. And I was saying, you know, I'm not an Ayurvedic physician. What can I say? And then as it happened, this was next slide, please. So actually, this is another thing. In Trivandrum, we stopped over and I had dinner with my parents and two ISRO scientists. And the whole evening was just amazing, amazing stories. So when the USSR was broken down into pieces, India had a very good exchange program with the USSR, but the USSR was broken down. USA came and stopped all the information coming down to India. So the director of ISRO said, you know what? We'll build it ourselves. So they were going to build a wind tunnel to test the products. And they had to get the knowledge transfer from USSR because USA wouldn't give it. The West and the Europe wouldn't give it to India. So they were having good relationship with the USSR, but that broken down. So now they had to build it. The person with the white hair on the right-hand side is the one who led the project. He built the project in whole wind tunnel himself. Just amazing stories, amazing stories. None of us know his name. I did not know him. I knew he's my father-in-law's classmate. I did not know he was behind all these huge, big projects. No one knows about it. Whereas, next slide, please. I happened to be in Kennedy Space Center in August on a family holiday. And look at the difference. Look at the difference. How the US projects what they have done and what we have done. It's a big difference. It's a bit, I mean, we are nowhere. I mean, of course, NASA is miles ahead of us, but Israel has done so many great things with very little resources that we have, right? But yet, that is where we're projecting. We're not coming out. We're not saying, listen, we have to be standing on the top of a building and shouting loud that this is what we're doing. This is what we can do. This is our brains. This is our own indigenous stuff. right? We got it all ourselves. So this at this point, I saw the parallel between Western medicine and what I call Ayurveda. I wouldn't call it complementary medicine, but I would call it Ayurveda. And this is exactly around the same time that Bomraji was saying, can you come and talk? So this is the comparison, contrast I could see there. And this is my perspective as an outsider, as I say. Okay, next slide, please. So as I said, we have to project the evidence. We have the evidence, we've got to show it. There's nothing to hide, nothing to hide. We shouldn't call it again, yeah. So we should call it proper medicine, we should put it out there, all the trials should be out there. And nowadays, we don't have to depend on the big journals to publish our evidence. We can actually go out and say publish our evidence on I don't know, YouTube or Instagram or whatever. There are so many channels to project our evidence. Next slide, please. So I'll quickly go through this. This is just something which we all have to go through that in the NHS. There's budget and spending. Next slide, please. And that's how much the NHS has been spent. Budget has been. But next slide. And the actual increase is that. So that in real terms, the actual is there, but the real terms, that is the funding. So because you have to account for the inflation, various other things. So actual funding is gone down for the NHS. Next slide, please. This is aging population in the UK. Everyone knows. And why is it important? Next slide, please. And this is why it is important. It costs more when you're older to treat. We all know that. Next slide, please. Same thing. We are not anywhere near the top in our expenditure in the NHS. Next slide, please. And the same thing reflects on the staffing of the NHS. Next slide, please. There you go. I know this. I see this every day of my life. They come. There are about 10 emails in my inbox asking why is this patient not being operated? Why is that patient not being operated? Why is they are waited so long and that sort of stuff. Next page, please. And this drug, yeah, we thought NICE is going to be really good. There's a big hoo-ha about this drug. There's a life-changing drug. They said no, we're not going to fund it because it's too expensive. So there you go. Next slide, please. So this is where I feel that, to get into it, it's so resistant. It's such a closed bubble, a closed thing, and so much of bias against Ayurveda. I think the project has to be, our aim should be to produce, publish, and project all the time, the evidence, whatever we have, we have to be true. We have to do a proper scientific way. We can't say, case reports or 10 cases or whatever. I'm just saying, again, I'm preaching to convert to the converted. Next slide, please. And whenever I tell my junior to say, if you want a quick publication, this is what I do. So first of all, it should be clinician-led. Don't worry about any of the industry or whatever, right? It has to be something that is high frequency. It has to be happening quite regularly. Something like appendicitis or gallstones or some hernias or something like that. And there has to be, the intervention should give you a tangible difference and it should be measurable and repeatable. And that's those are the 5 things that I give them. You find it, you come back, I'll support it. But behind all this, funding is always a problem. Next slide, please. Collaboration is so important, I find. If I collaborate with someone high flyer, I'm more likely to get a publication quicker out there. Next click, please. And I find more and more now, we probably need to have a champion, a celebrity minister or someone like that, someone who can actually pull the sound bites that we need. That's what I feel. Otherwise, this is the modern life. This is how it works. And we've got to play the game accordingly. Next slide. That's about it.